want to thank you all for coming out, whether it's by Zoom or in person. I want you to know I consider it an honor and a privilege that you think that what I have to say would be worth some of your valuable time in the midst of the busyness for medical school. So that's not lost on me, and I really hope I can make it worth your while. I think you know I'm Dr. Larry Birger, and I'm here to try and give you a prescription for, I put surviving medical school, but really for thriving in medical school. So yeah, I was hoping to catch some attention and really, rather than give a lecture on the latest treatment for diabetes or whatever, not that that's not important, but I was hoping to give you something more fundamental and, you know, how to not just survive medical school, but to optimize it, and particularly to pave the way for a career that feeds your soul. A little bit about my background. I won't spend too much time on this, but basically I think the highlight is that I have a real passion for evidence-based medicine properly understood, and for teaching it and imparting that to others, including patients. I developed a mentoring relationship and friendship with Dr. Gordon Guyatt. It's going on a decade ago now, when I wasn't satisfied with my own thinking as a physician. And so wound up connecting with him, and it's been a great thing. And as I told you, that the one article on surrogate endpoints, he was one of the authors of that. Some other things about me, involved in different evidence-based medicine endeavors, including the Washington State Health Technology Clinical Committee. A little bit of a sidebar on this. Music has had a profound effect on my life in a real healing way and sustaining way. And in 2018, I founded a nonprofit called Learn from the Masters Music Outreach, which is about sharing the healing power of music. And so if that gives you maybe a little bit better idea of who I am or what I'm about in a broader sense, if you want to check it out, you can go to lmmo.org. And then in 2022, two colleagues and I started what we call EBM-TIM, or EBM Truth in Medicine. And the mission statement, you can read it there, but this is about teaching people, patients, clinicians, whoever, what they need to critically appraise and navigate healthcare. I mentioned a little bit already in terms of my teaching style. A lot of this flows from my own frustrations as a learner. And I'm really trying to pack as much in what I'm presenting at any given time, putting myself in your shoes. And so you can see kind of bullet points of my philosophy there. I do like, for those of you who were on Zoom and didn't hear this, I really like paradigms in particular above facts, because how to think is much more important than what to think. If you're diligent and you're well taught in how to think, the other stuff will take care of itself, as long as we have the humility to be corrected by anyone and everyone along the way that can help us along. So there are going to be things in this that I put into the slides deliberately with the idea that we're not going to take as deep a dive as I would like to, because I could do multiple lectures based upon the things that I've presented there. So it was kind of difficult to pack all this together, but I thought it was better to put it in and expose you to it. But if you guys like what I present here tonight, if it's helpful to you, I would be honored again to come out and teach you more. So on this or any other topics, clinical topics, whatever. So we're gonna do a little survey. I think everybody can probably relate to this feeling, right? You know, you're drinking out of a fire hose. And so let's do a poll here. Medical school is exhausting, is expensive and exhausting, is expensive, exhausting, and demoralizing, all of the above. You don't want to answer because you're afraid there may be some negative consequences, or you're too depressed to answer, okay? So let's look at the goals. What do I hope to accomplish here? Well, I want to provide perspective and tools that will encourage, liberate, and empower you. And I mean, that sounds a little cliched, but it really is true. It frees you, and it gives you the power of soul and the power of mind to go through this process and beyond. And then, of course, with that, the goals of med school and pursuing a career that feeds your soul. How are we going to accomplish this? Well, I want to, number one, develop your full pancreatic potential. We'll note that talk isn't cheap, it's expensive. We'll do some talking about talking, and we'll use profanity to talk about me, which my wife and stepson would say is particularly appropriate, but that's another story. Some critical digestion, then applying those pancreatic tools. We'll learn the proper use of the telescope. We'll talk about bald tires running over surrogate ashtrays, and we'll ask the question, are grades, well, you know. Thirdly, then we'll get to the effects of digestion, which is nutrition, and I'm lumping that under the rubric of thinking like a physician. We'll look at the physician and me. Evidence-based medicine at heart is about challenging authority. We'll touch on some more words about words, and then we'll examine it, all of this by way of a physician named Evie. And then finally, we'll conclude talking about how the game is about the practice and not the other way around, and how that applies to the other previously stated goals. So developing your full pancreatic potential. I do like to be as interactive as possible, but of course we do have some time constraints. But what are the two broad functions of the pancreas in layman's terms? I would say to break down and to build up, right? And so do you know the word for breaking down? Catabolism. And for building up, anabolism. And so usually you would think of the exocrine function of the pancreas in terms of breaking things down. We're breaking the nutrients into their component parts so we can digest them. And then anabolic, indirectly, and it's enabling absorption of those nutrients, and directly with things like insulin. Well, I as weird as a metaphor as this sounds, I really do think it's apt, because that's what we need to do. We need to digest issues. We need to digest them properly, break them down, and then take what we've broken down and use that to build up. Talk isn't cheap, it's expensive. What do I mean by that? Well, who in here thinks that effective communication is important? Show of hands. All right, good. So it is expensive in the sense of its inherent value. How many of you in here are aware of the idea of self-communication? Have you ever thought of it in those terms? Maybe more so than previous generations like Dr. Klein and myself, but self-communication is critical. Whether or not it's an actual dialogue or whether it is just the messages that we give ourselves. So we have to be mindful of that. It's also expensive because it requires large investments of time and effort, right? This is hard stuff, but the return on investment is huge. And again, I have them listed up there, but I mean, off the cuff, what are some things that you think of as benefits of effective communication, especially in the doctor-patient relationship, but it doesn't have to be limited to that. Go ahead, fire off some answers. Anything. Listening, you learn how to listen better. What else? What are the results of effective communication?
Avoiding misunderstanding.
Doing what?
Avoiding misunderstanding.
Avoiding misunderstanding. Excellent. How will that help you in the doctor-patient relationship? Yes, help you make a better treatment plan, hopefully enable the patient to be better compliant. It helps to build trust. When you show that you're listening to a patient and you can reflect back to them and they see that you're trying to break this down into things they can understand, those are critical. It'll make us better clinical thinkers. It also can help keep us from being deceived and from inadvertently deceiving by spreading sloppy thinking. So talking about talking, if we're going to have effective communication, we've got to reflect on communication briefly, right? And none of this is really earth-shattering. It's just when you sit down and ponder it a bit, I think it helps it to sink in. So one of the things that I have found is focusing on the fact that words are defined in different ways, right? There are what they call reportive definitions. The technical term lexical, when we go to a dictionary and you see there's 8 different meanings of the word law or blast or whatever. Well, that's more of a historical description. It just reports how these words have been used or are used. there's a form of definition called stipulative. I'm going to stipulate that when I say telescope later in the lecture, it means da da da. And not to get into a linguistics analysis here, but just to be self-conscious of that. Why is that? Because we often speak a different language than our patients. We're still using English, we're using English words, but you talk about allergy in one way, they think of allergy in another. Oh, well, you don't have an allergy to that, Mrs. Smith. Well, what does Mrs. Smith mean by allergy? What does the patient mean by chest pain? Are you having any chest pain? No, I'm not having any chest pain. It was really more of a heaviness, right? Well, if we're not aware of that, we may miss a diagnosis. So imprecision, as you mentioned, Mohammed, it could lead to misunderstandings, which can lead to disputes. And by really attending to this stuff, we can find our way through. Is this merely a verbal dispute? And it's not an actual disagreement, or is it truly a genuine disagreement? I want to look at some examples. Are you familiar with the term syllogism, right? From an argument. Those of you who are not, a syllogism, when we talk about reasoning, an argument is two propositions put together in such a way that it proves the truth of the third proposition. So a major premise, minor premise, conclusion. All men are mortal. Socrates is a man, therefore Socrates is mortal. That's the classic, what we call categorical syllogism. So let's look at the minor premise here. This is going to help us illustrate the importance of language and give us some tools. So the major premise, some dogs are brown. All right. Minor premise, my dog is brown. Conclusion, therefore my dog is some dog. Okay, just ponder that. Here's another example. Can you see, you can see the heart of the jungle now well behind them, the three intrepid explorers entered the spleen. So Gary Larson, Far Side cartoon, illustrating the point I want to make here. So your future physicians, I'd like you to diagnose what just happened with the language there. What went wrong in the first syllogism or in the Gary Larson cartoon? Come on, lay it on me. Okay, in the syllogism, is the word some being used in the same way between the top and the bottom? No, it's shifted the definition. Likewise, in the Gary Larson cartoon, you've got heart of the jungle, and there in the cartoon, the humor is based upon the fact that he's referring to it as though it's a literal heart instead of a metaphor. Okay, so this is great in humor. This is disastrous in our communications when we don't attend to it. And I really want to key into this, because if you stick with me, I'm throwing a lot of stuff at you here, but stay with me, because I think by the time we're done, you're going to see how all this fits together. So does anybody know the word for changing the definition between the premise and the conclusion? It's called equivocation. And I think that's one of the most important things. It's like medicine. You know, we have specialized terms. Instead of saying the left part of my back above that thing that sticks out on my hip, you know, we would say left lateral lumbar or something. It's more precise. It helps us communicate more efficiently and precisely. So some of these terms, I'm not going to lay a ton of them on you, are going to help to do that. So let's talk about profanity to explain how all of reality is about me. First, we're going to go into a four-letter word beginning with F, and we'll have a D word and an S word. Actually, it's an SH word. All right, well, what am I talking about here? Well, the four-letter word beginning with F is fact. What's there, what's real. The D word, discern, how we know what's there. And the S word, SH word, should, what we're supposed to do with what's there. All right, why am I saying that? Well, this acronym, ME, Metaphysics, Epistemology, and Ethics. Have any of you ever heard those words before? Or are they foreign? Okay, you've heard them. Would you be able to define them in even a sort of casual conversational way if somebody said, hey, what's metaphysics? Now, I wouldn't have been until I was taught these by the late Dr. Greg Bonson, but I find so much of what he had to teach me has spilled over into what I do. So what we're talking about here is the facts, how you know the facts, and what we're obligated morally to do with the facts. Okay, I think we can all appreciate that. That's what we're doing in medicine. We want to discern the facts about disease and about our patients. We want to know that what we're claiming about treatment for evidence for treatment is solid, and we need to know how to apply that in an ethical way. Well, the technical terms for that, and again, I think you'll try it on, metaphysics, epistemology, and ethics, and you can say really, literally, that all of reality is about these things. That's why I say all of reality is about me. And again, a mnemonic to help remember that. And it's going to be a tool as we analyze things. So I'm going to make some statements or questions. You all have an obligation to be future physicians. You are future physicians. How do we know you are future physicians? Well, let's talk about those. Tell me the first statement. You have an obligation to be future physicians. Is that metaphysical, ethical, or epistemological in its focus? What? Ethical, right, because it says should, or you have some sort of obligation. How about the next one? You are future physicians. Metaphysical, ethical, or epistemological? What? Yes, I have some hearing loss, plus there's this fan going up here. So exactly, metaphysical, because it's a statement of fact or alleged fact. Now, if somebody said, if I said, hey, I gave a lecture to the future physicians the other night, they say, well, how do you know they're future physicians? And that would be then what kind of question or subject? Did I hear epistemological? Yeah, has to do with how we know things. And hopefully you're already getting a sense of how this, I mean, this is what we do in medicine. This is what we do in life. So this next then, some critical digestion as far as the proper use of the telescope. What in the world is a telescope? You may be convinced that my way of teaching tonight fully legitimizes the practice of psychiatry. When you're done here, if you conclude that, that's fine. But anybody know what it's called when you make up words besides idiotic? Neologism, right? So the word that is invented is a neologism. I am a neologizer. I try to keep that under control. And neologizing, you know, the process of making up words. And by the way, you see the roots in that, neo, like neoplasm, and the word for word, logism or logos. That, by the way, is a powerful technique that I have found has served me well in my learning, is just look at the root words, right? You guys have a distinct advantage in medicine once you onboard those, even in your reading beyond medicine. So telos, I don't know if you've ever heard that word, but it means the goal and or purpose. And skopos, I mean, or variants of it, either using as the verb form or the noun form, it's either an observer, a watcher, or that act. So why am I putting that here? Because we got to view things oriented towards their goal or purpose. And that's why I called it the teloscope. And I got this idea from something that will now date me, but a group called Rush. You've heard of them anyway, like in your archives or something? Never heard of them. Wow, I'm in trouble. Anyway, they were a prog rock group for about 40 years, and they had a line that said, the whole wide world, an endless universe, but we keep looking through the eyeglass in reverse. So they had, and I actually wrote an article a few years ago called Inverting the Telescope. Because I maintain that in society and in medicine in particular, as pertains to you guys, we got to turn this thing around and use it properly, or we're going to continue to screw it up. And I guess, you know, you guys are DO students. In my experience, if you have a DO who is really kind of trained in the philosophy of DO, you think a little bit broader, right? I mean, I'm assuming they're teaching you that here. And so I think maybe you can even take that more to advantage. So let's talk about tools in telos. If you're going to have an end, a goal, the telos, there need to be means to get there. And so we speak of the telos and the tools. And as you would imagine, the telos is going to determine what tools we use and how we use them. And so if I need to fix the backyard deck, I'm not going to go into the surgeon's operating equipment and, you know, grab his retractors and stuff. I could maybe do a little bit with that, but it would be just, you know, ineffective. So let's talk about one set of tools that is critically important. And in some ways, if this is all you get out of the lecture tonight, I would be happy, because this is profoundly important. Not just for medical practice, but for anybody who is a student. And I wish I could give a whole lecture or a series of lectures on it. Has anyone ever heard of a surrogate target, a surrogate endpoint, a surrogate outcome? Haven't encountered that yet. Okay. So that chapter from the text on evidence-based medicine, the user's guides to the medical literature, that's on surrogate outcomes. And a surrogate outcome is a substitute endpoint for a target outcome. All right. And they are tools, and properly used, they're indispensable, very beneficial, and improperly used or given an exaggerated emphasis, they become misleading and even dangerous. All right, you'll see where I'm going with this when we get to section 3 about the nutrition. Right now, we're digesting stuff. So what are the essential qualities for a good surrogate? That article goes into that in more detail, the one from the EBM book. But Dr. Welch talks about this in his little Changing the Rules article as well. There has to be a strong independent association with the outcome. They have to be part of the causal pathway. Intervening on the surrogate has to be meaningfully beneficial on the desired endpoint. And the benefits of intervening on the surrogate should be much greater than the downsides of intervening. Now, that sounds really abstract, and if I were you, I would probably be nodding off about this point. Well, what does that mean? All right, let's take a specific example. Blood pressure, arguably the first surrogate endpoint in medicine. In the 60s, they did some trials, small trials, about 70 people with severely elevated diastolic blood pressure. Well, did we really care about the blood pressure? No, they cared about what they thought that blood pressure would lead to: stroke, death, heart failure, blindness, really meaningful stuff. And those were the targeted endpoints, but you don't want to have to wait until you get there. And so they determined that if they intervened on these extreme elevations of blood pressure, it made a profound difference. Well, why is that? Because it met all these criteria. All right, well, let's talk about some real life criteria or real life examples of surrogates. And one thing I would encourage you to do is realize that so much of what we do in medicine, and this will help you communicate effectively with your patients, so much of what we do in medicine is the same as what we do in real life. I mean, if I'm trying to find out why my ice cubes are melted in the freezer, that's no different in principle than trying to find out why somebody has refractory back pain. Okay. And here we have, you recognize that, right? A tire. Does that look like a good tire? No. So bald tires for blowouts. I'm going to say this is a good surrogate. My stepson Kurt over there is something of a tire expert. I'm putting him on the spot, but he really is. The guy knows his stuff. And if you came to him and said, hey, can you check out my tires? He's going to notice things in the tire tread thickness and wear patterns that we may not notice. And he would be able to say, well, where is this in the link in the chain? It's linked reliably and causally with blowouts and accidents. Now, we don't want to get to the point of where we have a blowout and an accident, because then your intervention is going to be trying not to crash your car and lose your life, right? So what would the intervention here in this case be on the bald tires? What's that? Replace the tire, yeah. So we have a surrogate endpoint. We replace the tire. That's meaningful. That is a huge impact on the outcome, because if you drive on that tire that I showed you, you're crazy. And the upsides of replacing the tires, in that scenario, do they far outweigh the downsides? Yeah, I mean, you may be irked that they cost what they do, or you got to take 3 hours to get them fixed or whatever. Well, let's talk about ashtrays. Okay, what about ashtrays for lung cancer? Bad surrogate. Why? Well, I mean, after all, the presence of ashtrays is linked reliably to lung cancer, right? I don't think any of us would really dispute that. But is it linked causally? Does it have any meaningful relationship other than to serve as kind of a marker? Well, no. All right, are you starting to think about some of the biomarkers that have been proposed and they want to intervene on them and they do nothing? Well, they're like ashtrays. And so if you had a campaign to eradicate lung cancer, we're going to do this by getting to a 75% eradication point in our county ashtray count. Do you think that would accomplish anything meaningful? No. You'd probably piss a bunch of people off, and rightly so. And if you got somebody that said, screw this isn't worth it, I'm going to stop smoking. Well, that would be at such a high cost, it just wouldn't be worth it. Now let's talk briefly, and this is one where I really would like to spend a lot more time, but are grades expletives, right? Well, for some of you, there probably are. And I'm not saying that as an insult. I mean, anyway, I would be one of those that would be tending to do that. Let's apply me, right? Metaphysics, ethics, and epistemology. Now we're going to start to use these tools to something that's coming a little closer to home for you. And by the way, I'm going to define my term here. Grade, I'm using in a broader sense, not just ABC, but USMLE. I have my ABIM, American Board of Internal Medicine research exam next Tuesday. I'm not happy about that. I do think that's bullshit, but I got to do it. And so what is metaphysics? What is the nature of grades? Well, ideally, I mean, they're supposed to be promoting our learning and skill, right? And in an ideal sense, they would measure that accurately, but really in their use, they're a surrogate endpoint. And we're going to look very briefly. I give an article for suggested reading at the end of this. It does a really nice job of analyzing this. Let's look at the nature of motivation. What's an intrinsic motivator? Just look at the word. If you talk about an intrinsic versus an extrinsic motivator, give me an example of what might be intrinsic.
Passion.
Your passion. Is that what you said? Yeah. So I want to do a good job because whatever, it means a lot to me, or somebody's depending on it, or it's a beautiful thing. I want to play this song well because it's just a great thing to do. All right. And then there's extrinsic. What would give me an example of an extrinsic motivator?
Social acknowledgement.
Social acknowledgement. Very good. Yeah. I heard another answer, but money. Yes, absolutely. Right. Well, and I think we would agree intrinsic is far more important than extrinsic, but in their abstracted form, in their ideal form, they're harmonious. They reinforce each other, right? There shouldn't be a clash between wanting to do a good job and getting paid for doing that good job. All right. But we look at this distinction between the concrete and the real and the abstract or the ideal. Unfortunately, grades are very often at odds with the ends for which they were instituted. Now, what's the nature of the motivation provided by grades? Intrinsic or extrinsic, primarily? Extrinsic, right. I mean, unless you really have bought into the idea that grades are somehow really valuable, I would say it's an extrinsic motivator. So let's ask I'm going to pose some epistemological questions. What do grades tell us about their intended purposes? What do we know about ourselves or others by virtue of grades? What can we learn from them? Let's ask some ethical questions. What's our responsibility in our approach to grades? How should we grade grades? Well, we don't want to toss them out. I mean, the concept is a good concept, but what do we communicate to ourselves about our aptitude and our worth based on grades, either if we get good grades or mediocre grades or bad grades? What about others? The social acknowledgement or the praise? Well, I mean, is it true encouragement? Is it false encouragement? Are we being gaslit in extreme cases? And looking at grades through the telescope, I'm not going to dwell on this. You guys can look at this, but just purposes of grades in the abstract and the ideal, again, legitimate. The skopos, what do we observe of the general effects of grades in the real world in real time? Well, I had one instructor that powerfully captured it. She has taught a lot of medical students, residents, nursing students, and people over the years. And she said to her student, the fact that you got an A on my exam doesn't tell me what you learned. I think that may be the best way I've ever seen it put. And interestingly enough, this same teacher, if she had students that were not doing well on the test, but they came to her and she had sort of an oral boards kind of oral exam sort of approach. If they showed proficiency in that subject, she'd give them full credit on the test. Now, to me, that's a true educator. Positively, even grades as they exist now, they do force us to invest a certain amount of time, which, I mean, time is related to learning, perseverance, and so excuse me, so forth. But there's a lot of negative things I think we all know about grades in their current usage. I had one classmate many years ago describe this phenomenon of a shift from learning to gamesmanship. What do I mean by gamesmanship? We're doing what we need to do just to get the grades. And he described it as informational bulimia, binging and purging on factoids. And he said it in his Boston accent, so it was even funnier. But I think he captured it well, right? And so there are a lot of negatives from that. You can, and you can look at those examples in there. One of the concerns I have is that grades can foster what I call an intellectual codependency, where codependency at its core is deriving our worth, our value from the opinions of others or from something external instead of it being intrinsic, right? Well, I hope we can see that this is a very easy trap. I have felt it. I've felt this for decades. And what is the impact of that on your mental and physical health? It also can give a false confidence or an unwarranted timidity, and it unfortunately can suppress and even extinguish intrinsic motivation. Well, that's the opposite of what grades are intended to do. And I don't think you'll have any instructor that says, I want to have you do these grade things so I can make you hate learning, right? I just don't think that it's that nefarious. So I want to give some take-home points. This is really the punchline for this. I wanted to, because I know that med school is tough. You are drinking from a fire hose. Some of you may be doing quite well. Some of you may be struggling to maintain, whatever the case. I want to have a word that applies to everyone, but I want you also to know that when I give these criticisms and concerns about grades as surrogate endpoints, I'm not speaking from the perspective of somebody who's bitter and trying to justify myself because I didn't do well academically. I've always done well academically. So I just want to lay that aside. This is because I am concerned about what they're doing to learning. And I have a passion for people to experience the freedom that comes from really knowing how to think. So I'll tell you this. I'll just tell you flat out, I've been practicing for quite a while. I think Dr. Klein would probably agree with me on this. Nobody gives a shit about my grades or my test scores. I guarantee you they're not asking me what my USMLE scores were or grades in rotations or anything. They do not give a rodent's derriere. And they won't about yours either. That doesn't mean that grades aren't important right now. They're a necessary thing that you have to do. I'm not telling you don't go for the grades. You have to. But I'm saying you got to view these in a proper perspective. I saw Dr. Klein smile when I said that, because he knows, I know, and that's liberating to say, my patients will not care what my grades are. So you got to do what's required to get the grades, but always remember, generically speaking, grades in their current use are an artificial and simplistic construct for complex target endpoints. And I would say that's particularly true in medicine. All right. Intellectually, that's only part of the component of medicine, but even as surrogate endpoints for something, the intellectual processes of medicine, grades do not meet those criteria well in many cases. Again, I'm painting with a broad brush, and I don't mean to be, it's either or, but I see enough nodding that I think some of you at least are vibing with this. So good grades then, if you're doing well or striving to do well, good grades in medical school do not guarantee clinical aptitude. So if this is pretty easy for you or whatever, don't draw the wrong conclusion from that. That's some of that false confidence. It may reflect, but on the other hand, don't say that it's garbage either. This is the problem. We just don't know. It may reflect the necessary skills that will lead to a strong clinical performance, or it just may mean that you're good at taking tests that are very artificial and really have little or nothing to do with a good clinician. And this is one of the beefs that I have about having to recertify now again for internal medicine. I'm all about continuing medical education. I think that's vital. And if we sign up for medicine, we got to do it. But this is the point. I want to teach us the principles that we need to do that well, not spend $2,000 and tons of time preparing for a test where a lot of it will be informational bulimia. right? Even for us. So, but conversely, or as a corollary, I should say, struggles with grades in medical school do not guarantee a lack of clinical aptitude either. So if you're struggling, that you cannot draw, and this is the problem with grades so often. There may be a variety of factors that would cause the grades to be what they are. Do you know, have you heard the term confounder or confounding variables? Have you come across that yet when it comes to clinical studies? Well, confounding variables are things that introduce error or proneness to error, which is the technical term, that's the technical definition for bias when you talk about evidence appraisal. And so if there are confounders with grades, then they are not independently associated with their independent outcome, with their intended outcomes, the target outcomes. And in that case, they fail that criterion as a surrogate, don't they? So there may be factors, though, that led to the grades that any of us get that could be indicative of things that we have to fix or we're not going to do well clinically. This is what makes it so challenging. But there may be factors that have nothing to do with it. You've got family demands or whatever, you were sick or something happened, right? So if you go to this link, they do an excellent job in this article, really kind of dissecting grades. So let's get to the nutritional effects, what I'm calling thinking like a physician. So hopefully now you're going to see why this maybe sort of absurd, abstract, and why is this guy going through this? I'm hoping it will really coalesce. Again, I'm going to define my term. I'm using think as a physician in a broad sense of mentality, approach, motive, heart. Okay, not just strictly intellect. It includes the intellect, but it's a lot more than that. We're going to do the same thing. Let's look at the physician and me. We're going to ask some metaphysical questions. What is health? Kind of important if we're in healthcare, right? Is health feeling and functioning as well as possible, as long as possible? I think that's a pretty good definition of health. Or is it a number or an abnormality not destined ultimately to harm people that becomes a disease? As one author put it, you're healthy if we can't find anything wrong with you, quote unquote. Well, your definition of health, I hope you can see, is going to guide your entire approach to medicine. And if you're in administration, it's going to guide your administration or maladministration of medicine and healthcare. You can see why this is so critical, especially for us as physicians. How about what is a physician? I'm going to venture a definition like this. A physician is a servant leader who applies an accurate understanding of physiology and pathophysiology to help patients feel and function as well as possible, as long as possible. That's my mission. But it could also be defined as that same servant leader who's quite knowledgeable, who primarily applies their knowledge and skill to try and achieve surrogate endpoints that have minimal or no relevance to patient important outcomes. What are meaningful health outcomes? Are we looking at surrogate endpoints or what PIOs, patient important outcomes? You're going to see this in the literature. How patients feel, function, and survive. Whereas surrogates are numbers. We talked about blood pressure. You can look at A1C, body mass index, lipid values, right? And here's the thing where it's easy to get fooled. As soon as you represent any of those with a term, a label, instead of a number, we can shift into thinking that we're no longer at a surrogate endpoint. Well, no, you have the disease of diabetes. Well, how do you define that? Well, it's an A1C above 6.5. All we've done is put a term in place of a number, but it's still defined by a surrogate. So keep that in mind. Now, I'm not saying at some point it doesn't become severe enough that it really is a dis-ease. You know, if your blood sugar is 800, if your blood pressure is 280 over 140, right? But now we're talking about something that has morphed into something different. So let's look at the terms significant versus clinically relevant versus important to me. They're not the same, but most of what we will encounter is going to be clinically relevant or significant. Well, start looking at the numbers for actual magnitude of benefits. That's one of the things that Dr. Guyot and his colleagues talk about in that chapter. What's the magnitude of benefit? And that's critical. If you, and we're going to get to an example of that later on, but the magnitude may not be important to me. maybe clinically relevant. You may make public health policy on it or sell drugs or whatever, excuse me, whatever. And then again, what difference does being abnormal, quote unquote, mean to how I feel or function or how long I can do so? Metaphysics continued. What's the nature of evidence-based medicine? Somebody, who in here has heard the term evidence-based or evidence-based medicine before I came in? Okay, I hope you've all heard it, right? It's sort of a mantra. Who wants to venture a definition? Just give me a shot at a definition for what evidence-based medicine is. I couldn't have done that when I was sitting in your spot. I don't think I could have done that 10 years ago.
Is it best practice based on
what treatment options? You're onto something, yes. Best practice, but I wouldn't necessarily equate current treatment options with best treatment options. But yeah, the idea of best practice.
Scientific proven.
Yes.
Treatment.
Right. So now we're getting into the epistemology aspect. How do we know that this or that is good or not good? Well, that has a lot to do with evidence-based medicine, but it's not the only thing. According to the BMJ best practice, it's the application of the best available research, as you said, Mohammed, to clinical care. So this gets into your idea of best practice, which requires the integration of the evidence with the clinical expertise and the patient values. And what I have seen so often is that evidence-based medicine is really being used more like a club to beat people into submission. They tend to use it in a binary way. There's either evidence or there's not evidence, and that's not at all true. The first time I met Dr. Gordon Guyatt, he told me that evidence-based medicine at heart is about challenging authority. That statement really took me back. Was not what I was expecting. But he doesn't mean knee-jerk challenging of authority. I would say that what he's talking about is really involved in viewing healthcare through the telescope. What's the focus of this? Well, it blew me away when I learned that the third of three principles of evidence-based medicine is that evidence alone is never sufficient. It has to be applied according to the patient's values and preferences. I never heard a lecture on that in my training or after that in practice. You ever heard a lecture on that, Dr. Klein? Yeah, well, and that's not just Guyatt. I mean, a number of years ago, blanking on Brian Haynes, I believe, wrote an article called Evidence Doesn't Make Decisions, People Do, right? This is critical because if we don't pay attention to this telescope, what are we going to do? We're going to start browbeating people with the evidence that has been browbeating to us. Has anybody ever stopped to critically reflect on this, even if the evidence is good? Another statement that blew me away. One author I read said that he had one colonoscopy for screening. He had a first-degree relative with colon cancer, and he said, "No, thank you. I'm not going to take any other colon cancer screening, no colonoscopies." And he said it was a good experience and so forth. Like, his reason for that was that if they find a colon cancer early enough and they treat it, then that may enable him to live long enough to die of dementia like his mom did. And what really packed so much punch with that is this was coming from Dr. Welch, whose books I've featured up there, and you're getting an excerpt out of them. He is a leading expert in cancer screening. He was a lead author of the 2016 New England Journal article on screening mammography. This guy is no slouch, let's just put it that way. And that just took me back, like, wow, I mean, talk about patient values and preferences. He's got a point. And again, accountability to MEE, I just put on there. But I mean, ponder that statement, this idea of challenging authority. Really what it means is there has to be something higher than just expert opinion. And I know Dr. Guyatt well enough to know that he doesn't mean that experts are irrelevant or anything like that. But what is the nature of the patient? Is the patient a human being suffering from or seeking to prevent patient-important outcomes, PIOs, or are they a consumer accessing a product? Well, think about that the next time you're seeing reports on this. There are a number of epistemological questions. A lot of them we've discussed already. You can see them in your slides. Ethical questions. what's my responsibility as far as formulating clear ideas about these kinds of questions? Why do I say that? Because ideas have consequences. Philosophies, everybody does philosophy. Everybody has a view of facts or reality. Everybody has a view, whether they can enunciate it or not, about how we know what we know, whether or not we know things. And everybody has a sense of what is right or wrong and what we should do. Even if they claim it's a relativistic one, they're still going to insist that that's a moral obligation, which is, I don't understand how they can do that. But anyway, ideas have consequences. They have shaped and even destroyed entire civilizations. What is my obligation to my patients? Another ethical question. So let's talk about some more words about words. I want to revisit equivocation and just think about these terms now that we've reflected on this a little bit more. How about terms like endpoint, significant, quality, excellence? You're going to hear a lot on quality the more you go along in your career. And I think now you've got the tools to say, well, what do you mean by quality? Define your terms. And particularly this definition of health, as we talked about already. And I'm going to ask the question, what happens to the health of a nation or a family or an individual, but especially a nation in this case, when health is largely equated with attaining surrogate endpoints that may or may not have a validity? Ideas have consequences, and definitions are critical. Just as a sidebar, if you teach people that health is about attaining a number, you encourage them, or I would say discourage them, from pursuing things that will accomplish that number and a lot more. Well, I got my cholesterol down, my blood pressure down. Yeah, but you're still 75 pounds overweight and you don't move, and so forth. So let's look at a physician named Evie. And again, this is a metaphor, a mnemonic device as well, to try and remember what I think are some critical features, things that I have found to be most critical. She's got 2 arms for serving and 2 legs for walking. The 2 arms, what are they? Well, first of all, the telos of the arms, what is she reaching out for in the first place? Because she wants to help the patient. So as I said, that anybody who characterizes evidence-based medicine in any other way doesn't understand evidence-based medicine. This is ultimately about helping the physician and nurses and whoever else, respiratory therapists and whatever, physical therapists who take care of the patients to do it better in that, really kind of sacrosanct relationship of provider and patient. So what are the tools of medicine? Well, I'm going to say her arms correspond to the 2 primary tools of evidence-based medicine: diagnosis and treatment. And again, these are worthy of lectures. I'm going to try to illustrate it here, but you've been patient with me thus far, and I don't want to overload you. When you talk about diagnosis, you're talking about primarily, or largely anyway, pre-test and post-test probabilities. That helps you choose what test, right? I'll give a quick example. Somebody comes in, they've syncopized, they look like crap, they're hypotensive. You can do any number of tests on them, but you have to develop some sort of pre-test probability of what caused them to be in that situation. If they're 80 and they've got ischemic heart disease, you're going to be thinking down one path. If they're 16, you're going to be thinking down another path. You could do all kinds of tests. You could MRIs and EKGs and so forth, but let's just say they're 16. Suppose somebody says, hey, are you allergic to nuts? Yeah, I am. Do you think you might have had something that had nuts in it this afternoon? Oh, crap, I did. Boom, you've made the diagnosis. That pre-test probability that it's not this stuff and it might be something else determine which test you were going to use. And asking questions of patients, any bit of data that you get about your patient is a test. And that's another thing that makes medicine much more cool. Because if you think about the questions like, oh, I got to think about how I do this. I mean, right now you probably have to do this kind of shotgun approach where you got to go head to toe and so forth. But as you develop your skills in those, I wish somebody would have taught me this, because when this sunk in, it's like, oh, wow, this is pretty neat. And you can take something that's mundane and, at least if you're nerdy, it becomes cool. And so treatment is like shopping with coupons. We're going to get into that in a minute. I said she had 2 feet or 2 legs for walking. The first principle that I learned this from a guy who was teaching us in residency. This is my way of putting what he said. Keep walking until you explain the data in front of you. I'll give you an example. Friend of mine was reaching out to me recently about this chronic, that was actually subacute back pain. No matter what he did, it was not going away. And we went through a number of text things like this. He had seen the ER 3 times. He had an MRI in late August, right? And I asked him, well, you know, is there any indication that this is an infection? Why would I care? Why would I think infection with back pain? Well, you got to think of it always, but this guy had a kidney transplant a year and a half ago, so he's on immune suppressive medications. Well, there was no indication of that in the MRI in August, late August, didn't show anything. So we proceeded under the assumption that it was musculoskeletal. And anyway, then back and I finally said, you know, as he's telling me, got better for a little while, but now it's worse. I said, okay, you need to go see somebody now, because you know he's on the other side of the country, so they can do a physical exam, right? Because I didn't know what we were dealing with right now, but my post-test probability, if you will, and this is what a good test should do. It should either raise your probability or lower your probability. Otherwise, it's a worthless test. And in that context. And my post-test probability, meaning the tests that I had done by asking him these questions and seeing how he had responded to different treatment interventions over the preceding days, it was lower, at least it was starting to be questioned. Well, he went to the ER, and what does the guy have? Sadly, he has an infection of the disc in between his, at the level of L3. That really sucks. Well, why didn't it show up on the MRI on the 29th? Apparently too early in the course. But now it was showing up. And so there is a perfect example of keep walking until you've explained the data. But the second one, recognize your finish line, was also where I was at. When I say finish line, when I was a third-year medical student, we had a pediatric gastroenterologist who was teaching us. He said, I'm going to show you the most important thing in medicine. Oh, wow, that's really perk up, right? He had a whiteboard and he drew a line down the middle. This is the most important thing in medicine. I'm like, huh, you want me to play some fanfare music here or something? He said, this line represents the boundary between what you know and what you don't know. And he said it is critical to delineate that. And he said in any given topic, this is going to shift one way or the other, depending on how much you're working with stuff. I was much better at dermatology in years past than I am now. My knowledge of eye issues is really primitive because it's just not within my wheelhouse. I have to know enough about eyes, for example, to know that does this patient need to see somebody or can they treat it conservatively? That's really simple. And so in this case, with my friend, it's like I had reached my own finish line. Like there's nothing more that I can diagnose from 2,500 miles away by text and so forth. I would need to do further testing that I can't do. Physical exam is what I had suggested. But then, of course, he went to the ER and they repeated the MRI, rightly so, and it was an astute call. So remember, 2 arms, 2 legs, diagnosis, treatment, keep walking till you've explained the data, know where your finish line is in terms of knowledge. If you're working in a busy clinic schedule, you don't have time to look up like you'd want to maybe, and spend 2 hours reading on how to work up a patient for a condition. You say, this is as much as I know, I got to refer them to endocrinology or whatever. So let's look at how Evie practices medicine. So which approach to controlling A1C, lipids, and blood pressure produces meaningful results over 6 to 12 months? We're going to take patient A. These patients are going to be ladies that are in their 70s. First patient is going to the intervention is going to be diet changes, a simple daily schedule of awakening times and bedtimes, light exercise, and senior yoga. The other one is not going to make any significant lifestyle changes, but by the time this process is done, it's been put on metformin, Januvia, glipizide, lisinopril hydrochlorothiazide, amlodipine, and atorvastatin. Anybody know the word to describe what just happened there? Polypharmacy. Polypharmacy is a bad thing, especially the older we get. So let's look at patient A. Well, this lady lost 25 pounds. Her knees don't hurt like they did before. She's more mobile and flexible. Her balance and coordination have improved. She's sleeping better. Her stress is reduced. Her mood is improved. Her A1C is 6.7, which at least last I knew, that would have been an appropriate treatment goal for somebody in their 70s. LDL 95 and systolic blood pressure 128. Patient B, this lady gained 5 pounds. Her knees are still stiff and painful. Her activity tolerance is a little worse. Her balance is still off at times. She needs to take a sleeping pill. She's got more relational stress. She's frustrated with how she feels and functions. That's causing her to be depressed, which is causing more relational stress. And her life is getting worse. But look at this. Her A1C is even better than patient A. Her LDL is better. And her systolic blood pressure is at goal. Wow. Okay, which one of these is health? A or B, in your opinion? A. All right. What's the focus in medicine? If we look at this through the telos scope, what gets the emphasis? What are you going to be able to accomplish when they expect you to see 4, 5, 6 patients an hour? Really hard to intervene on lifestyle interventions. Ideas have consequences. So let's look at how Evie practices medicine by applying evidence wisely, not being sucked in by big pharma or other agendas, or let's call it shopping with coupons for savings that are actually meaningful. So we got coupons here, say 50% off, 15% off, whatever, but it's going to be a certain percentage off. So tell me, which one is better? Would you rather have 10% off or save $100? What's that? Exactly. You don't know. There's not enough information. All right. So in order to find the financial savings, you got to take the regular price times the coupon value and then get the total savings. So if you're at if your coupon says, hey, you get 50% off and you go, but you can only use it at the dollar store. Well, it's probably not worth the drive. But if you can use it at the furniture store or a musical instrument or a car, well, hey, sign me up, right? So in medicine, you have something called relative risk reduction. Anybody ever heard of that term? Okay. That corresponds to the coupon percentage of reduction. And generally speaking, this is a bit overly simplified, but generally speaking, that is going to be the same across populations. All right. So 30% off, 25% decrease in risk, 65%. Warfarin reduces the risk of stroke and AFib by 65% approximately. Does that tell me what my benefit is from taking warfarin if I have AFib? No. Why? What? Right. You got to know the risk. You got to know the price of what it is that I can put that coupon toward. So we have to do this by taking the baseline risk times the relative risk reduction of the therapy. And that gives us what I'm calling our health savings. Another, the technical terms for health savings in this illustration would be absolute risk reduction or risk difference. I think risk difference is a better term. Dr. Prasad in the book that I have back there agrees, and a lot of people agree with that, but it doesn't matter. You'll probably see it referred to as ARR. Have you seen that, absolute risk reduction? That's the money shot. When you're looking at an up-to-date article and it tells you this or that benefits or whatever, well, first, just at a glance, what's the magnitude? This is the magnitude of benefit. And of course, the magnitude of benefit is going to be dependent upon the baseline risk of my population. So which is easier to sell or to promote by appealing to fear? We're going to use vague language. Wunderpil reduces the risk of this horrible disease X. You don't want to get syndrome X. Well, how about this? Wunderpil reduces your risk of syndrome X, a deadly, terrible thing that you don't want to have, or so it's said, by 40%. That sounds pretty compelling, right? That's a marketing approach. How about an evidence-based approach, Evie's approach? By the way, if you didn't gather already, Evie if I didn't say it stands for evidence-based medicine. So you would say if your baseline risk is 10% over 10 years, and by the way, you would explain what is Syndrome X really? Is it the next bubonic plague, or is it more akin to arthritis, which is not like that's not a small thing, but if your risk is 10% over the next 10 years, Wunderpil reduces your risk of Syndrome X by 40% of 10%, because it's only going to reduce whatever your level of risk is. So that means out of 100 people like you over the next 10 years, only 10 of you are destined to get Syndrome X. So those are the only 10 that can benefit in the first place, right? And so 40% of those 10 will benefit, which is 4. And by the way, you've got to take this medicine daily for over 300 or over 3,600 times over the next 10 years. 4 will benefit, 96 will not benefit. And we haven't said anything about side effects. Does anybody know the term when we say 4 out of 100 will benefit? We could say that's an absolute risk reduction of 4%. There's another way to express that is very helpful, especially for patients. Have you heard of that? Number needed to treat. Has that term come up yet? And it's just a different way of expressing the same thing. 4% is a number needed to treat of 25. 2% is a number needed to treat of 50. 1% is a number needed to treat of 100. You see where I'm going with this? If you had a 0.1% increase or improvement, then you're talking 1 in 1,000. And so you can tell patients, well, this patient, if you had 100 of you in the room, or I'm sorry, if we would have to treat 25 patients like you for 1 of you to benefit, and we'd have to treat you over 10 years. Now you can use that to try and say, so maybe we want to consider some alternatives to treatment. Yes.
Somebody needs to treat, the smaller is better,
Yes.
but in that case, 4 out of 100, the
20.
bigger it is, the better it is.
That's because there are different ways of expressing the same thing. So 4 out of 100 is 4%. But if you want to say, I want to put it differently, how many patients would I have to treat before I would get 1 benefit? 25. Okay, 1 of them has benefited. 50. Now 2 have benefited. Go up to 75.
The better.
The smaller the NNT is, the better. The larger the absolute risk is, the smaller the NNT will be, and vice versa. Good point. And by the way, just so you know, and I would encourage you to read on this. He talks about it in his book, Overdiagnosed, Making People Sick in the Pursuit of Health. You know what the number needed to treat was? By the way, you also have to look at the time span. If you got to treat somebody for 10 years or 10 months or 10 days, right? That's going to make a difference in terms of compliance, side effects, and so forth, cost. But what do you suppose the number needed to treat was for the initial blood pressure studies that got all this started in the late 60s? Right now, my understanding, and Dr. Klein, maybe you can weigh in on this, I think it's generally considered worthy of acceptance if you've gone below an NNT of 40, right? Roughly. It's going to depend upon the condition. But as you pointed out, the smaller, the better. But if you use 40 as kind of a cutoff, well, that's a risk reduction or a risk difference of 2.5%. I mean, maybe that's valuable to people. Like, it depends on your endpoint, right? Well, if I'm trying to prevent death and I want to live long enough to, see my family, make it to some milestone or whatever, well, then that may be worth it. But this is why it's so important to understand this stuff and not just be, this dispensary of things that we've been told to do. The NNT for those initial blood pressure trials, I think it depended upon whether you were talking like 3 years or 1.5 years. But as I recall, in 1.5 years, they found that the NNT was less than 3 to prevent a meaningful outcome. That's incredible. We never, rarely, I would say, see things like that now. And so why was that? Because their blood pressures were so extremely high. So when something is markedly abnormal as a surrogate endpoint and you intervene on it, then the odds of them benefiting are much greater than if as the abnormality gets closer to normal. Okay. So I was going to go through this, but in the interest of time, we won't. Check out this website. There's a guy named Victor Montori. He's an EBM expert. He's an endocrinologist at Mayo Clinic. And he put something together that not only helps people decide on taking statins to prevent a first heart attack. Anybody know the term for that? It's called primary prevention. Secondary prevention would be if you've already had a heart attack or you already have the disease and you're trying to prevent something worse from it. So this is intended for primary prevention, statins for primary prevention. But I think the real value of this website goes beyond that because it shows you how this process works. It calculates your approximate risk. It puts it based upon different factors from a risk calculator. And then the intervention will reduce it by such and such a percent. And then you'll see it graphically on the other side, the smiley faces being the ones that benefit, the frowny faces, the ones that don't. And Dr. Montori has also started something called the Patient Revolution for, I think it's for kind and compassionate care. He wants to do something about what he calls industrialized healthcare. And I would encourage you to check that out. Dr. Welch sums it up like this. If the American public knew the full story about the benefits, harms, and uncertainties of medical care, many would choose to have less, not less care, less medicine, meaning the interventions of testing, medication, procedures, surgeries, and devices. And make no bones about it, testing is an intervention. It subjects people to a certain amount of risk in most cases, maybe just financial risk, or the risks of a false positive that could cause you to go into a tailspin. Oh, crap, do I have cancer? You know, do I have HIV or whatever? And that's beyond the scope of this lecture. But so let's conclude here. The game is about the practice, not the other way around. What do I mean? Well, I'm going to use a term that is really for didactic purposes. It is intentionally pejorative, but I don't want to overstate it. Okay, I'm going to talk about the game of healthcare. And I don't mean to imply that the game of healthcare, as I've called it, has no relationship whatsoever to the practice of medicine, because that's not true. There is overlap, and depending upon where you're practicing, what you're doing, you're familiar with Venn diagrams, right? Where you have sets and how much do they overlap. There is some overlap, and it could vary. But I'm just as a general concept, I hope you already see by now that there's quite a bit of non-overlap between those two sets. That's the problem. And that didn't happen overnight. And what I'm trying to do right now is to help you guys be equipped or start to be equipped to make a difference, at least in the realm of your own practice and with your colleagues. I don't have any delusions about reforming the system, but we don't need to worry about that. We can make a difference where we are. And so, you know, example, my mom had emergency cardiac bypass surgery a little over a year ago. I was very impressed with an organization that nevertheless I have a very low opinion of. But they did a great job on that. And so there was a perfect example, I think, of the intersection of the game of medicine. And maybe in future lectures, I'll come up with a better way of putting it that doesn't paint it so negative. And I do want to say a word here as well. When I speak of healthcare, I speak in these generalities, and this will be a critical point for you to really onboard. I'm not attacking any particular individual. I'm not attacking their motives, certainly. I'm looking at the system itself, the natural outgrowth of the system, what the system has produced thus far. Okay, because there could be good-hearted people that are in that have false beliefs about healthcare. And this is why I said earlier, if we are thinking about these things carefully, if we don't, we could be part of that going in the wrong direction, which is, you know, going contrary to what we really want to accomplish. So I'm talking about what you might call systems integrity. It's a systems analysis. The game of healthcare. Okay, unfortunately, the fact is, administration within healthcare, again, I'm speaking in a really broad sense. I'm going to include insurance companies and government regulatory agencies and hospital healthcare and so forth, clinic management and so on, is administered primarily by those who generally don't understand the practice of medicine. Okay? If they had the same, I mean, I think you can already see, if they don't have the same definition as you about health, probably going to have some clashes. All right. Many of the metrics are marginally meaningful. And that, frankly, that's putting it politely. I didn't include it in here. I just got a feed from Medscape where they said that one organization they looked at, there were 57 metrics that primary care providers had to meet in order to get their quality-based pay. Well, you see why I'm raising questions about, I'm saying, look, don't take my word for it. You asked the questions yourself. What does quality mean in this case? How could 57 metrics in the midst of a busy practice really be quality, especially when these are imposed by people that don't understand what you understand? I'm not saying that all practices are like that, but that was a pretty extreme example, and it's obviously out there. Okay, as you probably are aware, and you will become increasingly aware, there is a morass of regulations and regulatory agencies that govern medicine. This is there, right? There's nothing we can do about this. What about the practice of medicine? What is it? Well, I'm going to say that the practice of medicine consists, when it comes to physicians, of servant leaders caring for patients, striving for patient-important outcomes. To me, that seems self-evident. You don't care about your A1C unless you've been indoctrinated. All right? I don't walk around saying, hey, Christine, my LDL feels so 183 today. I know it. My mood is dark and it's gotta be the LDL of 183. I need to get down to 105, right? That's ridiculous. But you'll talk about how you feel. You'll say, I feel fatigued. I can't function as well. What's wrong? Okay. So identifying reality, just in a general sense, identifying reality for what it is allows us to play the game with the intrinsic motivation of practicing medicine. Seeing our way more clearly on this, I'm going to argue, it certainly has done this for me, I think it's done it for Dr. Klein based on my discussions with him, that it just gives you a perspective that allows you to look above all that to the goal without being gaslit that a lot of this bullshit that we're being fed is supposedly the truth. And there's a statement, and I didn't come here to advertise for my company, but it was one of the things early on that really refreshed me. I was talking to one of the billing people. I work for a group called Apogee Physicians doing hospitalist work. And the billing person said, yeah, if we're gonna stay in the game, you have to play the game. And I think that's kind of aphorism that is floating around. That's a great way to view it. And if you've got a company that is doing that, it means they're seeing things for what they are rather than trying to convince you that things that you know are not meaningful are meaningful. All right. So because this is a reality, I'm going to suggest to you that we need to conscript everything possible from the game into the service of the practice, even if it's not directly related. Okay, I got to jump through these hoops. What can I gain through this process that will still be beneficial for my practice of medicine? Let's take what I'm dealing with this irritating recertification exam that I have to take every 10 years unless I do this other thing that they have, which in my opinion is even worse, for the American Board of Internal Medicine. Well, I have to look at it and say, like it or not, I got to take this test. So what can I get out of it? Well, my wife is a veteran respiratory therapist, and we geek out on a lot of these medical things, and we analyze ABG results and all kinds of weird stuff. And we talk about medicine. So that's one thing that I've taken from this, is it really putting me in touch with things that I love about analyzing medical issues. At least getting exposed to things that I know I'm going to forget, but oh, there's that term again. And maybe in the back of my mind, somewhere, some way, somehow, I'm going to have this vague remembrance of it that could make a difference. Those are just a couple of examples. And some words of caution. So if you're using the telescope the right way and taking this, what I'm calling a me-centered approach, and really asking basic questions about what's in front of you, that may make you very unpopular with those who favor an industrialized approach to medicine. You need to be aware of that. So I contend that we are called to be servant leaders as physicians. I feel very strongly about that. What does that mean? That means we should be a servant, and that means that we should be leaders. Leaders are confident. They're humble enough to be taught, but they also have this strength to do what's right. And if they're good leaders, people who have eyes to see are going to follow them naturally. Well, if you're on an agenda for things that are not in the agenda and plans and blueprint for people that want to view healthcare like it's more of a factory model, you need to be aware of that and know how to navigate it. And so what I'm going to tell you, and this is particularly true right now, early in your training, you know, you guys may go, you may say when I'm done here, man, I could not wait until that guy was done. I hope not. But if you take away from this, like, no, wow, this is really something I want to onboard. And the more you do it, and you might get upset, as I have many times over this stuff. Okay, now is not the time for you to be making a lot of challenges. When I said evidence-based medicine is about challenging authority, that's, please don't misunderstand me. Because you can ask questions, raise points, but don't take that kind of approach, please. I've done it too much myself and over the years, and it doesn't work. And this is true of when you're a resident as well. Just be wise. And I would say the other thing that I would instill in you is begin right now to have a view toward working where you're allowed to think like a physician. That's critical. I've been in both. I've been in organizations where we were, and then something morphed, and the atmosphere became very toxic. So that is a really important principle. The company I work for now, again, not to make this into an advertisement, but I bring it up because I think that those who are doing it right should be also noticed. The motto of the company is what's best for the patient is best for the practice. And I have used that to stand my ground against manipulation occasionally that has come up from, say, ER providers who want to muscle me into admitting somebody who doesn't belong at that facility. And that's my defense. Look, this isn't best for the patient. And if you've got a company that actually, or an organization or whatever, a context where they actually believe that, and you know how to think your way through it and conclude what is best for the patient, you're in a really good position because now you can think and act like a physician. All right. So how does this help me survive medical school? I did tell you that I wanted to present you with some encouragement on that. I hope you're seeing some applications, but I'm going to say that getting this proper perspective through the telescope, seeing things as to their ultimate end or purpose, and subordinating the tools and the use of the tools to that end purpose. What does that do? Well, it has a liberating effect emotionally, that clarity of mind. I don't know how else to describe it, but it really is freeing. Well, that in and of itself is worth its weight in gold. But it will free you in other areas as well. It'll help you to be freed up to be a better thinker. You know, it's almost like being, are any of you musicians? No? Anybody play any instrument? Well, take something, whatever it is that that might have a passion about, your golf swing, your tennis, any hobby, it doesn't make any difference. And somebody shows you some simple things about technique or about, you know, how to play the game or whatever. Whoa. And suddenly you're liberated to do it better than you ever could before. You know, you kept hitting a roadblock. So I'm going to suggest that this perspective and these tools will help you transcend the short-term things that are a part of the game rather than part of the practice. If nothing else, you're going to say, all right, how can I take this, you know, memorizing scads of information and puking it out on a test? That's not the real world. And in fact, I don't want a physician that practices like that. The memory is too fallible, right? But that's the fact of life. That's a fact even to a significant degree of the test that I'm going to have to take on Tuesday. No, it is what it is. So how can I make that subordinate to the practice of medicine? That may require some creativity. And I'm going to say right now, there are any number of things in the educational process that are good, just in general and in medicine, but there are things obviously that are not good. And the things that are not good, I'm going to say that's your introduction to the game of medicine or the game of healthcare, because that dynamic doesn't go away. But if you were in the military, it wouldn't go away. If you were in industry, it wouldn't go away as part of life. It also liberates us, and in the particular context of medical students, from false views of our aptitude that arise from the game, right? So if we see this properly and you're struggling in medical school because X, Y, or Z, and there are things that really aren't related to your knowledge or aptitude, well, then don't gaslight yourself. Be free from that. I think hopefully you have some sense or a renewed sense of purpose and intrinsic motivation, because that's what I'm trying to stir up here. And I would say that generally speaking, I'm going to guess that people in medical school are going to have a higher intrinsic motivation than the average set of students in any class, right? You're here, you've worked very hard to get to this point, and you continue to work hard and not have your head blown off by that fire hose. That's commendable. Intrinsic motivation is critical. How can we maintain that throughout residency or fellowship or your practice? And then, as I said, it'll give you a better idea of how to make even the negative, unrelated things about the game serve your purposes. So how does this give me a career that feeds my soul? Well, you've got the fundamental tools, or at least some of them, necessary for the practice, and the practice, the goal being for you guys to be servant leaders who are doing something meaningful for patients, rather than being a technician or the healthcare version of a factory worker. And it shows this perspective that even in the midst of a very broken healthcare system that shows no promise of any significant cure, in my opinion, I hope I'm wrong, you can still do much good. You may have to work harder to do it, but I really want to leave you with that. You get through this process, you think about it the right way, you navigate wisely, and you can do good. And so it helps build trustworthiness. It'll allow you to transform your culture, even if it's just the person next to you or the patient in front of you. And I want to leave you with this. You'll notice that I did not say that this approach is going to give you a financially successful career. I hope it does, but it might cost you as well, because you're standing for what's right and you take another job that pays lower, or you run into, malfeasant administrators or whatever, and you get screwed. That happens more often than I would like it to. Let's just put it that way. So, but what you do have here is practicing medicine with integrity and a true sense of purpose, knowing that you are truly thinking in this broad sense like a physician, and you're becoming more and more skilled in that. That brings rewards and riches that no amount of money or any other perk can buy or bring. And that is what I want to leave you with. I thank you very much for enduring this lecture. And I really hope this is beneficial. We have just a little bit of time left. I don't know how to hear from people on Zoom, but any questions that you have for me, I would be happy to have Dr. Klein answer for you. If you're wondering, Dr. Klein is an adjunct faculty at with the Knoxville campus, or the whole school, or I don't know how this works. Yeah, and so he kindly drove in from Knoxville to attend this and probably make sure I wasn't misleading the youth or whatever, but he's my boss in Apogee Physicians. And my statements about Apogee were not brown nosing, by the way. That I said that because I believed it. And that's why I'm with the company, and that's why he's my boss. Because I could be working in other places and I didn't want to. So are there any questions? I know it's longer than I intended, and I apologize for that. I hope it was worth your time.